Hello, everyone. Welcome to the Zoom call today. We're sorry for the delay, but we're here. So we're going to start off the session, having that we're already 5 minutes of time. And I'm going to welcome the first speaker, who's Macharia. So Samuel Macharia is a project officer, user and survivor of psychiatry in Kenya, that is USP Kenya, where he works towards advocating for rights of persons with psychosocial disability. My experience his experience as a person with psychosocial disability has been shaped by passion in ensuring that he gets many just voices as he can, strengthened by being a self-driven advocate. He's also been able to support other persons with psychosocial disability to claim their rightful space in their societies. Much of the project work that he's been able to be involved in USP-K, that is users and survivors of psychiatry, is on advocacy for the inclusion and access for service in the community. So this includes access to education, health justice, as well as social protection, as envisioned in the Constitution of Kenya, the Convention on the Rights of Persons with Disability, among other legislation. So Macharia is driven much pride in supporting persons with psychosocial disability to form and run peer support groups in various places where he works. Now more people with the psychosocial disability are advocating for inclusion of their communities and also working towards eliminating the stigma and discrimination often directed to them. So Macharia is going to share his experience as a program officer and a survivor at the same time. Welcome, Macharia, and thank you for joining us today.
Thank you very much for giving the opportunity. I do also want to add that users and survivors of psychiatry in Kenya is part of the implementation of the Quality Rights Project from WHO alongside other organizations and the Ministry of Health in Kenya, which has set up the Secretariat. And Quality Rights is basically based on 5 thematic areas, which are extracted from the Convention on the Rights of Persons with Disabilities, that is the CRPD. And the first theme is the right to an adequate standard of living, which is Article 28. The second one is the right to enjoyment of the highest attainable standard of physical and mental health, which is Article 25 of the CRPD. And then the right to exercise legal capacity, that is in Article 12. The 4 is freedom from torture and cruel and degrading. And then 5 is the right to live independently in the community. And then more often than not, you find that people with different mental health conditions or psychosocial disabilities find themselves on the receiving end. They never get to access some of these rights as provided by the CRPD. And also our constitution talks about the highest attainable standards of health, that is in Article 43. So even before this COVID-19 era, people with psychosocial disabilities have been met with a lot of violations on their dignity and basic human rights. For instance, they've been denied access to proper treatment, standards of living. They live in poor conditions as a result of joblessness and poverty. They never get access to medication, clean water, and also personal security is highly compromised, and many other aspects in the community. And specifically during this time of COVID-19, and we've seen it from the press and from other sources, a lot of violence has been unleashed on the people with different impairments. To say, beginning with the domestic violence by spouses and even relatives don't want to spare them at all. They are emotionally and sometimes physically abusing them. And we also see the implementation of curfew and quarantine, whereby the police are not informed or are not instructed to spare people who respond differently due to the manifestation of the impairments, because some people are out there, the impairment has caused them not to respond like any other person. They may not have access to information about curfew sometimes, and others are restrained, whereas the impairment may force them to be moving around. And whenever they are met by the law enforcement officers, they are brutally handled sometimes, and even have had cases of some of them ending up in death or severely injured as a beating from the policemen. And also there are some of them live out on the streets. They don't have a specific home. Yet the decree is people should be staying back at home, locked, and maybe working from home. Majority of people with psychosocial disabilities do not have an abode they can call theirs. And therefore they're out on the streets, and when when the police are doing their rounds, they find themselves on the receiving end. They're brutally beaten and other forms of violence exacted upon them. And they don't have a way of explaining or claiming for their place. They don't have a place to report. They don't have a fallback plan on how to handle these things. So we found that a good number of them are now out there injured. Others are seriously injured. They cannot move around. And this is a very serious violation of their basic human rights and freedom. The right also to live independently in the community, you find that due to the impairment and the various barriers caused by daily interactions with the various institutions and structures in the community, they're not able to access the available opportunities. First, it's due to the stereotypes and stigma and discrimination given against them by the societies. They are perceived to be different from other people. They are treated as subhuman. They never get jobs. And even if they get the jobs, they do not get adequate remuneration. Therefore, it becomes difficult for them to sustain their livelihoods in the society. And then we also find that we don't have a very clear support system structured, maybe only for a few who have resources and maybe who could access these services. Maybe, and also who have families that understand their conditions. Otherwise, the majority just live at the masses of the community. It's upon the community members to give them what they feel they like, but it's not upon them to exactly claim what is theirs. The other problem is access to legal capacity, because basically every human being is entitled to be a legal entity as long as you have a human background. But now you find that even out of these violations of human rights and not even being able to claim their rights, decisions are made on their behalf, either by the family members or the various institutions or the various agents from the government and the private sector. And some of them are coerced into treatment and incarcerated, and they are not even able to move around, which means their liberty is highly compromised. And also, as I said before, even it becomes difficult for them to access basic hygiene facilities and even basic nutritional facilities, because they may not afford to buy foodstuff, and they also may not afford to access some of these places. And we had one major problem during this lockdown period, whereby even moving from one point to the other to seek help is difficult. Like now, the barrier between Rironi, which is in Kiambu, and Tigoni Hospital, which is in Lemuru, and it is the closest government facility which could offer treatment. But then due to the barrier, you find that one cannot go and seek medication or medical attention from the closest government facility. But now it's a bit better because the barrier has been moved ahead, and now it's easier to access the facility from last week.
So thank you, Macharia, for that, and really appreciate for the elaborate and well said advocacy work you're doing, and for elaborating one more on what you're doing within your platform. So we're going to take questions after every panelist has spoken. So for now, I'm calling upon Dr. Soumitra Pathare. So Dr. Soumitra Pathare, is a medical doctor, PhD holder in psychology. He's a consultant psychiatrist and director of Center for Mental Health Law and Policy at the Indian Law Society, uh, Pune, India. His primary interests are in the areas of mental health policy, scaling up mental health services, rights-based care, and legislation. He has provided technical assistance to the Ministry of Health and Family Welfare Government of India in drafting India's new Mental Health Care Act 2017, which takes a right-based approach to mental health care and provides for public-funded universal mental health care. He was also a member of the Mental Health Policy Group appointed by the Government of India to draft India's first national mental health policy released in October 2014. He has served as WHO's consultant in many low and middle income countries, Botswana, Seychelles, Lesotho, Samoa, Vanuatu, Eritrea, assisting them in drafting and implementing mental health legislation and national mental health policies. He is as well the principal investigator of QualityRights Gujarat project since 2014 to 2016, which implemented the WHO QualityRights program in 6 public mental health facilities in Gujarat. Is also currently involved in scaling up at Timiata, I hope I pronounced it well, across Mehsana district, Gujarat, with a population of 1 million at Miata. Is a project to improve access to mental health services in rural areas by training and mentoring women leaders of microcredit self-help groups to provide basic psychological intervention and access to social benefits for a defined and rural population. He is the project director of Spirit Hub, which will run from 2017, which runs from 2017 to 2022, a collaborative initiative of Center for Mental Health Law and Policy, that is ILS, Pune, Trimpos, Netherlands, SNHA, Chennai, and BCC, Bangladesh, with the Department of Health and Family Welfare Government of Gujarat, funded by NIMH, USA. Spirit is scaling up and evaluating 3 universal suicide prevention interventions in a cluster randomized controlled trial. Spirit also has capacity building initiatives to improve implementation research capacity in South Asia, as well as the capacity of policymakers to use specific evidence for making policies. So I'd like to welcome Dr. Soumitra to take us through his work and what he does. Karibu, thank you and welcome.
Hi, thank you. Thank you, Brian. Thanks for the long introduction. I just would like to start off by apologizing that I have not got my video on, and you wonder why, but we basically had a cyclone which has passed us in about 100 kilometers away. So we are without electricity, and I'm worried that my data will run out very soon, and so I've kept the video off so that I can conserve the data for this particular session. So thank you so much for inviting me, especially to Dr. Simon, who sent me the invitation, and also to Quality Rights Kenya for organizing these online webinars and workshops. And it was great listening to Samuel talk about the kind of situations that do prevail around in Kenya. I was going to talk a bit more from the perspective of taking a much more overview of this whole issue around abuse, coercion, and violence that we are talking about today. And I think what I would start off by doing is to actually add one more word to that, and that would be neglect. In many countries, neglect is as much of a problem as violence, abuse, and coercion is. And that needs to be addressed. If you look at these issues around coercion, violence, and abuse, then you can look at them from the perspective of institutions, and that is where most of the conversation internationally seems to have happened, which is about preventing abuse in institutional settings. But I think it's equally important that we also focus on the kind of violence and coercion that happens in community settings, and not forget that at all. So talking about institutional settings, and I'm sure all of you, since you come from the same setting in a sense, I work in a low and middle income country, and you are in the same kind of situation. And very often I find that one of the biggest problems that staff face in many of these institutional settings is the lack of resources. And the lack of resources manifests itself in many sorts of ways. It manifests itself in terms of having few staff. So there might be a whole ward full of 50 or 60 people who one nurse has to look after. And then it is almost practically impossible for that nurse or a doctor who's looking after 100 or 200 people in an institutional setting to be able to provide any kind of quality care. And a lot of the human rights violations that happen, especially around physical abuse, which happens around violence, which happen around coercion, can actually be traced back to these systemic and structural problems that do exist in institutional settings. And the lack of resources leading to the lack of staff is probably one of the most important issues that governments need to address in these institutional settings. The other important issue that I found in our setting, and I'm sure this must translate to Kenya too, is the lack of training. Many staff who work in these institutional settings actually have very little training. They have very little continuing professional development. Many of them have actually not even had a professional qualification at times, which allows them to be trained to look after people. And if you don't have the training, then it becomes extremely difficult to be able to manage difficult circumstances. And it becomes easy, or it becomes almost inevitable that in settings like this, where you have a shortage of staff, untrained staff, that people will end up experiencing either neglect or abuse or even actual physical violence at times. Sometimes the violence may not be physical, it might be verbal, but violence is violence nevertheless. So it's important that if we are looking at the health system or the mental health system, then addressing these resource deficiencies towards the staff is equally important. The other aspect that resource deficiencies create is the fact that very often people are put into these institutions in very crowded circumstances. There's not adequate space, there's not adequate chance for, say, recreation, there is not adequate chance to keep people engaged and being able to do something. And this kind of lack of resources to have good quality of care then creates circumstances in which abuse and violence happens. And so we need to also look at the structural, the physical structure and the availability of things like something for recreation, something to be able to have a quiet space for yourself, to not have to live in a very crowded circumstances is equally important. So I would say that in institutional settings, one of the biggest problems has been the lack of investment in good quality care that can be provided. Having said that, the other issue that comes up is that very often people are in an institutional setting when they don't need to be there. They really don't need to be in an institutional setting, but they are there because we have not created any adequate, good quality community facilities where they could be supported within their own homes. Very often family members will bring somebody who's disturbed and insist on admission, not because they like to put their relatives into an institution and lock them up, but because very often they have no support at home, they have no facilities, and very often they have no financial and other resources. And so that is something that the mental health system has really failed to do, which is to provide adequate opportunities for people to be treated in their home, with their families, in a manner that would then be acceptable to them. And what happens as a result of this lack of availability of community services is that people wait long. People wait till things get really bad before they get taken to some mental health facility which is quite far away. And so at that point in time, then usually there is no other alternative but to admit them into a facility, even if the family member or the person themselves may not wish to get admitted. So that is another issue, which is the lack of good quality community care. And the third and important issue is that we have policies and we have laws which actually encourage situations in which abuse might happen. So let me explain what I mean by that. If you have laws which rely predominantly on coercive treatment, do not rely on voluntary treatment, then you're going to get much more of that abuse. Because when you put people into coercive settings, or you coerce people into a setting they do not wish to be there, they are likely to get upset. And that upset will then get manifested in some sort of way, which will be responded to by staff with either physical or verbal violence. And so that is something else that happens very frequently. And so we need to also look at our policies and our legislation and see whether those legislation and policies are actually designed to keep people out of institutions and to use institutions as less as possible for as little a time as possible and as voluntarily as possible. And that's something that in many low and middle income countries like India and Kenya is something that we seem to have failed to do very well. So that is another issue that we do need to address before we can actually try to start addressing this in institutional settings. Turning to community settings, I think it's important to also realize that that violence and abuse happens in communities. And in communities, it can happen in the broader community outside, as well as it can happen within families. Let's take the broader community. Many people with mental illness or mental health problems end up being homeless. That's a reality in my country, and I'm sure that is a reality in your country. And when you're homeless and you have a mental health problem, many of them end up getting physically, sexually, and emotionally abused on the streets. And we do not seem to be able to provide them with any care which would either prevent the homelessness or actually get them out of situations of homelessness into a setting. There are programs like the home, Home First, as it is called, from Canada. This has now been done in India. It's called Home Again, where they try and get people into settings where they have much more control over their lives. And in those settings, clearly you can prevent abuse as well as violence. Now that's again missing in many developing countries like India and Kenya. And finally, we should not forget that at times abuse also happens in people's homes. And that abuse can be of different varieties. In India, it is not very uncommon, for example, for family members to mix medicines into somebody's food and give it to them because they feel they will refuse to take medicines. And this kind of surreptitiously giving medicines is something that happens not infrequently with people with long-term mental health problems in our setting. And that is a type of coercion. And it is especially damaging because it is coming from someone who that person trusts and sees as somebody close to them emotionally. And so coercion and these issues happen even in families. And let's not forget that there are almost a lot of the abuse, even for people who don't have mental health problems. A lot of sexual abuse, for example, actually happens in families. It's very rare or it's less common for sexual abuse to be perpetrated by strangers. And when you are vulnerable, like people with mental health problems are, then the likelihood of sexual abuse from within families is equally high. Uh, what worries me is that our societies and our governments do not invest enough to support families to be able to provide care. Because in most countries, like I'm sure in Kenya as well as in India, the lack of community care really means that it is families who are looking after people with mental health problems. And these families receive no support. They don't receive clinical support, they don't receive financial support, they don't receive any guidance, they don't receive any training. They're expected to just cope with it. And frequently in situations where you have an elderly parent looking after an adult with severe mental illness, then you can understand why violence or abuse might happen. uh, it is not about trying to blame the caregivers, but to say that our system fails to provide any kind of support to those caregivers. And so these are some of the, if we wanted to address the issue of violence and abuse, then these are some of the areas that we do need to kind of intervene and do something about. And finally, one of the most important things that I would like to talk about, because it impacts hugely on the violence and abuse, is the attitude our societies and communities have towards people with mental health problems. There's actually systematic discrimination that happens, and this systematic discrimination actually results in giving out the message that people with mental illness are in some sort of way as if they are lesser human beings. And that somehow justifies the abuse and the violence that happens. In our societies, if somebody was violent or abusive to someone else, people would intervene, the society would intervene. But by creating this discrimination and structural barriers to people with mental health problems, we kind of normalize the abuse and violence that happens by saying that, because they are not equal to all of us. In many countries like India, for example, your marriage could be dissolved if you had a mental health problem. If you have a mental health problem, your right to vote would be taken away. What do these things give out a message to society is that these are not people who are equal with all of us. They are somehow lesser than us because they shouldn't be voting, they shouldn't be marrying, they shouldn't have a job, or even if they don't have a job, it's fine. And this kind of gives out the wrong kind of message. If we want to get rid of abuse and violence, then it's not going to go away unless we create a culture in which every human being is seen as equal and respected for being a human being, irrespective of their mental health problem. And I think, so this is, if we wanted to address abuse and violence, then this is all the range of activities and areas where we actually need some intervention happening. I'm going to stop here and hand you back to Brian, and I'm happy to stay online and take any questions at the end. Thank you so much for patiently listening to me. I hope my accent was not too difficult for you to get.
I think everyone was okay with that, and I really appreciate the insight and input you've given. It was so intense, but we really think that there's so much need of having policies hearing you speak, I felt like we really need so much to do on policies and legal frameworks that help persons living with psychosocial disability really come out. Having heard from Dr. Soumitra, I think now we're going to take it now to another line where now, what are these legal implications? How is the law protecting the persons living with psychosocial, intellectual, and cognitive disability? So I'm going to call upon our next speaker, who is Faizah Sidi. Faizah Sidi is an advocate of the High Court of Kenya of 4 years standing. She works at the Kenya National Commission on Human Rights at the Research and Compliance Division, which coordinates the Commission's work on enhancing compliance with regional and international human rights obligation, including the Convention of the Rights of Persons with Disability. Key focus of her work includes review of legislation, research, and coordinating the Commission's and civil society's participation in the Universal Periodic Review. So welcome, Faizah Sidi, and kindly take us through the legal perspective of that governs violence against people living with psychosocial disability. Karibu.
Thank you, Brian, and hello to everyone and all participants. Thank you for having me, and thank you to the Quality Rights team for organizing this webinar, as well as inviting me to be a panelist on the same. I work at the Kenya National Commission on Human Rights, and just a brief background of the Kenya National Commission is that we are a national human rights institution created under the Constitution with a mandate to promote and protect the rights of all persons in Kenya. And this includes persons with disabilities. And a lot of our work also at the Commission focuses on the rights of persons with disabilities and how the government is complying with its obligations under the Convention on the Rights of Persons with Disabilities. And just by way of background, to answer your question, Brian, is that Kenya has ratified the Convention on the Rights of Persons with Disabilities, which in short, prescribes the standards and obligations that the government must adhere to when dealing with persons with disabilities, including persons with psychosocial, intellectual, or cognitive disabilities. And relevant to this discussion are a few articles that people should note that are within the convention, which include the right to life, the equal recognition before the law, which has a close connection to legal capacity, the right of persons to make decisions concerning their lives, and the right to have those decisions respected. The right to liberty and security of the person, also freedom from torture, cruel, inhuman, or degrading treatment, as well as freedom from exploitation, violence, and abuse. So these standards within the CRPD truly protect persons with intellectual, psychosocial, or cognitive disabilities from violence and abuse. Closely related to that is our constitution, which also prescribes standards that protect persons with disabilities from violence and discrimination, including the recognition of the inherent dignity of all people, protection from violence and exploitation. Just to pick up from where Brian, where Macharia and Dr. Soumitra have left, I was also asked to deal with what the impact of this violence are on the recovery of persons with mental health conditions or intellectual and cognitive disabilities. And I think this question is relevant because in order for us to end the practice of violence, coercion, and abuse against persons with mental health conditions, intellectual and cognitive disabilities, it's important for us to consider, understand, and internalize what the impact of violence and coercion has on persons with disabilities. And it's important, and I'm glad that in this webinar we've included a user. It's important to hear and learn from persons with lived experiences as to how this violence, coercion has impacted them. So some examples of impacts of violence and coercion is, of course, it has a negative impact on them. And first, to just note that it has inherent trauma, they face emotional trauma or re-traumatization, which often leads to poor recovery outcomes and the need for long-term care. Other consequences would include, if the violence is coming from a caregiver or family member, there's that loss of relationship or trust with caregivers. So who consent to coercive practices or who perpetrate the violence against the person. So, and in the context of Kenya, where most people with psychosocial, intellectual, cognitive disabilities live with their families, this is critical because the support of families is an important component in the recovery of a person. If the violence is coming from the service providers or the system, as has been elaborated by Macharia and Dr. Soumitra, is that there's often a reluctance by persons who want to seek mental health services, persons with intellectual cognitive disabilities, to seek further services from service providers or systems due to the loss of trust and fear that they would otherwise get violated in the process. And lastly is that the impact of violence and the coercion is that it further fuels stigma against persons with psychosocial, intellectual, and cognitive disabilities. So I think these are some of the impacts that ought to be considered, but overall from the Human Rights Commission is just to state that violence and coercion is a human rights violation and ought to be addressed with the seriousness it deserves. The ways in which we can prevent this violence and coercion, and I think Dr. Soumitra has touched on some of these issues. I think first is to address the stereotypes and stigma that drive people to violate persons with psychosocial, intellectual, and cognitive disabilities. So stereotypes which where people perceive persons with mental health conditions as being criminals or as being violent, as being a sin or a curse. I think it's important for us to debunk myths and stereotypes attached to having a mental health condition or having an intellectual or cognitive disability. This is important as part of the steps in addressing violence and coercion against these groups of people. And part of dealing with these stereotypes is awareness raising, which should be multi-stakeholder. And I'm glad that Kenya is implementing the QualityRights project, which would go a long way to addressing some of the stereotypes and attitudes that people have against persons with psychosocial and intellectual disabilities. I think the second thing is also addressing the systemic issues that have been identified in the presentations of the first two panelists. That is investing more resources within mental health systems and rethinking our mental health systems so that we're able to provide, one, community care at community level, good quality community care, as well as care within institutions, and capacitating them in a way that would prevent violence, as has been explained. Address the legal and policy gaps that are currently within our legislation that would encourage violence and coercion against persons with psychosocial and intellectual disabilities. And in this, I'd use the example of our Mental Health Act, which was enacted in 1989, and which, if you look at its provisions, sanctions coercive practices against persons with mental health conditions. So it sanctions seclusion and restraint. It allows for forced admission, forced treatment. So some of these provisions ought to be addressed in order to be able to address the legal and policy gaps that allow for violence and coercion against persons with psychosocial and intellectual disabilities. There's a process that is ongoing, and in the process of amending the Mental Health Act, it's important to reiterate that we need to include and fully involve persons with psychosocial, intellectual, or cognitive disabilities, as well as their representative organizations in this process, as required under the CRPD. their full, meaningful, and active participation in processes to amend the law or processes that interrogate systemic gaps that allow violence and coercion against persons with psychosocial and intellectual disabilities. Also is the other thing I would prefer in terms of prevention would be within facilities, strengthening complaints mechanisms where persons with psychosocial, intellectual, and cognitive disabilities with supports can be able to complain, and these complaints are redressed, they're given very important in addressing the culture of violence. Part of the reason why violence is rife, the Commission reckons, is that we do not have systems in which could address the complaints that of violence and coercion that occur against persons with psychosocial, intellectual, and cognitive disabilities. So addressing complaints mechanisms and providing support to persons with psychosocial, intellectual, or cognitive disabilities to make complaints and have them redressed is also something that is critical towards ensuring that we prevent violence and coercion against persons with psychosocial disabilities. Lastly is that the COVID-19 has brought in new dynamics in how violence and coercion is experienced by persons with psychosocial, intellectual, or cognitive disabilities. In addition to the gaps and the culture of violence that already existed before COVID-19, I think COVID-19 has brought in new dynamics which have further exacerbated the problem. And probably just to highlight that, the restricted movement and long periods of interaction, people living within locked spaces has also increased the likelihood for sexual and gender-based violence to occur during this period. And just to reiterate also during the COVID-19 period, we should note that with the government regulations to control the spread of the pandemic, including the use of cafe challenges, where we've also received complaints as a commission of persons with mental health conditions being beaten by police for being out during curfew. Also ought to be addressed in this discussion as to how we are addressing how persons with psychosocial, intellectual, or cognitive disabilities are experiencing violence during the COVID-19 period. And just to end my presentation, some of the things that we ought to consider in our discussion would include, how do we ensure continuity of care during COVID-19 with either shutdowns or scale down of existing outpatient services, methadone clinics, and support services for persons with intellectual or cognitive disabilities? How do we address continuity of care? Because I think this is also crucial in terms of addressing issues to do with violence and coercion. And lastly, how are we ensuring that there are preventive measures in psychiatric units and institutions, as well as homes of elderly and children? How are safety measures being implemented to ensure that we don't neglect persons with psychosocial, intellectual, and cognitive disabilities within these institutions? I thank you, and I want to hand you over to Brian.
Okay, thank you very much, Faizah. That was so elaborate and insightful. Sorry about that. So at this juncture, I would really like to now open it up for Q&As, plenary, for people to bring in inputs or questions. I'm already seeing people contributing within the question platform. So you can either place your questions on the chat or the Q&A section. And to start us off, I think this question is generally open to the panelists. So how do you help persons who are facing violence from their caregivers who are not even able to raise a voice because of not having a safe place? So this is one of the questions that I think I'll direct to any panelist who is ready to answer on this. how do you help persons who feel that they don't have a voice and they're being violated, they're living with a psychosocial cognitive intellectual disability? Yes, I open it up to any panelist who's able to bring it forth clearly.
Hi, Brian. This is Soumitra. I did type my answer, but I would like to repeat it again. I think this is where there is a crucial role for both professionals, healthcare professionals who are looking after a particular person, and a role for broadly for human rights defenders and human rights organizations and NGOs which work with people with mental health problems to ensure two things. One is that the person is offered alternatives, that the person is offered choice of somewhere else to live if they feel that they are facing abuse from their own caregivers. And that is where even the government needs to get involved in providing alternatives for community living. And the second and important thing is to provide them with support if they wish to complain about the abuse. You know, if they wish to make a complaint, either a formal complaint to the authorities or complaint to their other family members, then providing them with support is very important. And finally, the other important thing that that mental health services need to do is to actually provide caregivers with training and support on how to handle someone who has a mental health problem and whom they are looking after, because caregiver burden or the you know, the burden of when you're looking after someone who has a long-term mental illness is equally an issue, and very often caregivers face burnout too. So I think it's important to provide support not only to the person but also to their family member. Yeah, I'll stop here. Thank you.
Thank you, Dr. Soumitra, for that. Faizah, do you have any addition?
Okay. So the question of addressing, especially sexual violence against persons with psychosocial, intellectual, and cognitive disabilities is a complex one. And I agree with Dr. Soumitra in terms of his proposals. But in the Kenyan context, I think we need to address the barriers to accessing justice that persons with disabilities face on a day-to-day basis. And by barriers, I mean how actors in the criminal justice system prevent, you know, complaints around sexual violence from being handled to its conclusion until the person has an effective remedy. And in this sense, I think we need to address barriers such as communication barriers. How do we support persons with psychosocial, intellectual, cognitive disabilities to complain to police or other authorities when they have such complaints, and also of other criminal offenses? And you would note that in the Kenyan context, these supports are glaringly lacking. Secondly is how, once this complaint has been made to the police and eventually makes its way to court, how does the judiciary and how do judicial officers handle such complaints, noting that also in some legal systems, including ours, persons with mental health conditions are considered to be they're not considered to be competent witnesses. So what I'm proposing is we also need legal and policy reform around supporting victims and witnesses with psychosocial, intellectual, or cognitive disabilities to testify and give evidence in court. I've seen a question here on the Zoom chat now that I'm on the floor. How do we engage in disaster risk management on the impact of COVID-19? I think there's an opportunity for stakeholders present to be able to engage various government agencies, including the Senate Ad Hoc Committee, which is currently receiving memoranda on what should be done in terms of the COVID response by the government. So I think there's an opportunity to engage the National Emergency Response Committees with memorandum and, you know, trying to push the issues that surround persons with psychosocial, intellectual, or cognitive disabilities. And I think the Commission, together with stakeholders present, have been able to submit a memorandum to the Senate Ad Hoc Committee on COVID-19, setting out recommendations of how the government should ensure that persons with psychosocial, intellectual, or cognitive disabilities are taken. I think that I would answer that question that way. Thank you very much.
So thank you for Faizah for that. Macharia, I don't know if you have something just briefly to add on that. And as Macharia is going to pick up that, so Dr. Soumitra, there's one question that has been directed to you on how do you ensure patients who refuse to take oral meds do so in a safe manner? This is actually a common practice in our Kenya setting. I think there's been that issue of coercion in our facilities where patients are usually forced. How do you address that in a clinical setup? So Macharia, if you have anything to add on the first question and how do you engage the government based on your program, then Dr. Soumitra can pick it up from the question that has been addressed to him kindly. Samuel Macharia.
Hello.
Yes,
Can you hear me?
yes. Yeah,
Okay, thank you very much. Thank you very much. Both Dr. Soumitra and Faizah have articulated very well the issue of community healthcare, because from my experience, the community structure works very well because, like, for instance, we have community volunteers who know each and every person within that locality. And if it is handled in a multidisciplinary setup, that is the formal mental health system, which will include the community health volunteers and the local administration, it is going to articulate on all the issues surrounding provision of the necessary government care, which also includes resource allocation. If they are facilitated well, they can really have a good impact, as well as the welfare of the people with cognitive and psychosocial disabilities are concerned. And also looking for alternatives, like now embracing occupational therapy, which has been neglected. It is very instrumental as an alternative to supporting recovery plan for persons with psychosocial disabilities. Thank you very much, Brian.
So Dr. Soumitra, the question, how do we ensure patients who refuse to take oral meds and do so in safe manner? Yeah.
Okay, look, this is a problem at many levels, and giving medicines without people's knowledge is not a solution to it. I think the problem starts at, first of all, starts with poor communication between professionals and people who are supposed to take medicines. Very often, professionals don't spend sufficient time in explaining to people with a mental health problem about the need for taking medicines. And that need is not conveyed properly, or the alternatives to medicines are not conveyed properly, or the alternative types of medicines that are available are not conveyed properly. So there is an information issue which professionals need to address in the first instance. The second issue is to actually address some of the reasons why people will not take medicines. Let me tell you that the rate of non-compliance with medicines among people with diabetes is about 50 to 60%. And the rate of non-compliance with medicines in people with severe mental illness is also about 50 to 60%. So clearly non-compliance is not an issue about the mental illness, because the rates of non-compliance for diabetes and mental illness are the same. Clearly there's something else going on which we are not addressing. And one of the biggest barriers to compliance or adherence to medication is the side effects that medication cause. And very often people very justifiably do not wish to take the medicines because of the side effects. And frequently in busy outpatient clinics or in inpatient wards, very little time is devoted by clinicians to discuss what are the potential side effects and to see how those side effects could be addressed or reduced, or what could be done. So providing alternative medicines, for example, trying to work out which side effects matter the most and addressing those are equally important. The third thing that does not get addressed in communication with clinicians is that taking medicines is something that requires negotiation. But very often people with mental health problems are just told, here is your prescription, you need to take this medicine for the rest of your life. And the problem with that is if the medicine is causing side effects, or if you're putting on weight, or if it's interfering with your sexual drive, for example, then you feel particularly unhappy taking those medication. So allowing people to choose when they wish to stop medication is an equally important strategy in a long-term, if you're looking after somebody for the long term. I don't think just blanket insisting take your medicines ever works. I think it's important to have a negotiating stance where you're willing to talk to the person and say, okay, if you go off the medicines, what are the possible risks? How are we going to handle it? If you are going to go off medicines, what safety nets can we put into place? If you're going to go off medicines, what other treatments can I provide you with? And what are the symptoms where you might want to then say, okay, I need to go back on medicines. And I think if you have that kind of an open conversation with people who need the medication, then I think it's much more likely that they will adhere to the treatment because they see themselves then as partners in the treatment. And finally, and most importantly, after you've done all of that, if somebody still does not wish to take the medication, then it is their right not to take the medication. If you're saying that this person is well, they're living home, and they do not wish to take the medication, then after you've done all of this in a sensitive manner, you provided the safety net in place, and they still do not wish to take the medicines, then I think we should allow people that choice. And we all make mistakes. And in fact, in life, we learn only by making mistakes frequently. And so allowing people to make that mistake is also an opportunity to allow them to learn. And so we shouldn't shy away from that. And not taking medicines is not the end of the world. Keeping continuous contact, having a clinical relationship which continues even if they are not taking the medication is probably far more important than just making medicine as a single point focus of all clinical interventions. Yeah, thank you.
Thank you so much, Dr. Soumitra, for that. And I'm looking at our time, and we're already past 3 minutes. So I'm still seeing questions trickling in, and some of them have been addressed by Dr. Soumitra already. I'll not go through that. The rest of the questions, I really apologize that we might not be able to address each and every question that is being brought forward to us. However, these questions are going to be given to or addressed back to the panelists, and we're going to give you feedback based on the same. So thank you so much for bringing forth your comments and your questions, and for the fact that you're very much interested in how to go forward with this. So I really like to take it further at this point now to invite the panelists, just briefly in 2 minutes, your remarks as we close, and just 2 minutes. What are your final remarks to the audience and participants today? I'll start off with Macharia, Samuel Macharia. Just 2 minutes. Yeah, thank you.
Thank you very much, Brian. Mental health conditions should also be looked as a cultural, not only as a health issue, but also as a cultural and spiritual issue, and hence bring on board all the stakeholders, that is the cultural leaders, opinion leaders, spiritual leaders, and also try and come to a round table and discuss how issues can be articulated, which vary from one community, from one personality to another, and then maybe incorporate them in the conventional mental health practices and also this will go a long way in informing the formulation of laws and policies that are going to guide service provision as far as mental health is concerned. Thank you very much, Brian. I hand back over to you.
you, Macharia. And I really like that the fact that we need to enhance on more advocacy and awareness creation on that. So I would like to call upon Faizah, Faizah, for just 2 minutes legally on legal issues. How do we address this, and what are your final remarks on that?
Okay, my final thoughts is that we need an entire shift in terms of how we deliver mental in pursuing these interventions. I think it's important to, and I emphasize this, that we must include persons with psychosocial, intellectual, cognitive disabilities in this conversation. They must be involved actively and meaningfully in order for them to be able to bring to the fore their experiences and issues when these discussions are taking place. Thank you.
Thank you, Faizah, for that. So lastly, I would like to call upon Dr. Soumitra just to give us final remarks on clinical perspective here.
Thanks, Brian. I'm not going to take very long. I think I have only 2 or 3 sentences to say. One is that it's 2020. It's time for a change. It's time for a new beginning, and it's time for doing things differently. And change is possible. We have the knowledge, we have the tools, we have the technology, and hopefully we have the determination to bring about that change. So change is not only necessary, not only is it possible, but it needs to happen now. I don't think we can allow another generation of people with mental health problems to face the kind of abuses that many previous generations have faced. And we have to kind of stop this and start differently. Thank you, Brian.
Thank you, Dr. Soumitra. And one thing that I've really picked out from that is this change starts with us, and it's upon us to start implementing and pushing up for that change. So at this point, I really like to thank all of you, all the participants and the panelists who came today. We really appreciate for your time and for coming through this session and for the particular webinar. So I really like to encourage all of us most of us who are not already enrolled in the Quality Rights training, please go on the Quality Rights website, WHO website, which we are going to share forth within our platform, various platforms. Enroll and do the courses that are there, very insightful. More on what we've discussed today, you're going to find there, and you'll find a lot of information that's very relevant to either your work or your community program that you're doing. And I would really like to again welcome you for our next session next week on how quality rights has an African perspective. How do we view quality rights and African perspective? Is it something that can work for us? Is it something that probably it's yet to really bring forth another discussion within our African context? So kindly let's meet next week again and join in the training, which has already been shared on the chat section. Please log in and start the conversation going within your spaces and within the platforms you have. Thank you very much. I've been your moderator today. Brian Otieno is my name, and I really appreciate for your time and participation today. Thank you very much. Nice time, everyone.
Thank you, Brian. Thank you for inviting me. Bye-bye.
Bye.
Thank you, Brian.
Thank you.